Greetings. I'm Brenna Bray. I have a PhD in biomedical science and neuroscience and complementary and integrative health postdoctorate training that focused on eating disorders and specifically binge eating disorder. Now, my work focuses on adult binge eating disorders, but as we know, adult binge eating disorders tend to begin in childhood with pediatric care. So that's what I'm going to talk about today is how we can take the findings that I have on adult binge eating disorder, trace them back to their roots, and what you might need to know as pediatric care providers to help really address these root causes. So, very quickly, just some affiliations. I'm the founder, director, and CEO of the Nourished Research Foundation in Boulder, Colorado. We're a 501(c)(3) organization that uses research to improve the understanding, awareness, prevention, treatment access, and clinical and lived experiences of folks with eating disorders and other issues of health disparity and social justice. I'm an associate professor at the National University of Natural Medicine, a research investigator at the Healthcott Research Institute. I'm a core faculty at the National Institute of Health's Bridge program, which provides postdoctoral training to clinical researchers. And I'm also an adjunct associate professor at Naropa University, which is a Buddhist-founded university in Boulder, Colorado. I teach in the clinical mental health counseling master's program and in their psychology department. I want to give a very quick disclaimer. Some of the content that I'll be presenting today will be activating. There will be issues that address oppression, invalidation, marginalization, discrimination, bullying, abuse, and trauma, both generally and specific to populations of racial, ethnic, sex, gender, and socioeconomic status minorities, because all of those issues pertain significantly to binge eating disorder. I want to start with a little contemplative activity. If you will indulge me, I wonder if you might close your eyes and imagine that you have a patient or a patient's parent or a friend come to you and express that they or their child are communicating to them or expressing negative emotions related to their eating. Feelings of guilt, shame, loss of control. And I want you to think about how you might respond. If there are any follow-up questions you might ask. And I want you to just notice if there's any imagery that comes up for you around that patient or parent, friend, family member, specifically related to their body shape or size, their sex or gender identity, their race or ethnicity, their socioeconomic status, or their age. When you're ready, you can open your eyes and just kind of set that aside. Now, most of the work that I'm going to be presenting today is published. It's from my postdoctorate research, which was funded by the National Institute of Health here in the US. If you'd like to scan this QR code, you can follow along with the publication that I'll be pulling facts from primarily. This was published in 2022 and addresses environmental factors that experts and literature associate with binge eating disorder. I've also published on mental health aspects that pertain to binge eating disorder, clinical aspects that pertain to binge eating disorder, as well as complementary and integrative health use, treatment access barriers, gastrointestinal issues, and reward regulation that pertains to binge eating disorder. So what is binge eating disorder? Binge eating disorder is an autonomous DSM-5 diagnosis. It's characterized by 2-hour binge eating episodes that occur at least once a week for at least 3 months, in which an individual rapidly consumes large amounts of food, larger than others would in similar contexts, which can make diagnosis very challenging in adolescents and pediatrics. When their body's growing, their appetites change, their eating behaviors change. It's associated with loss of control and distress, as well as feelings of disgust, guilt, or shame. And I want to make a point here that it is very distinct from anorexia nervosa and bulimia nervosa, psychopathologically as well as neurobiologically. One distinction is that these eating behaviors occur without compensation. That distinguishes binge eating disorder from bulimia nervosa. but it is an entirely different pathology. Binge eating disorder has high lifetime prevalence rates. Most folks, when they think of eating disorders, they tend to think of anorexia nervosa. Anorexia nervosa has a lifetime prevalence rate of less than 5%, whereas binge eating disorder has a lifetime prevalence rate of between 23 to 31%. The Global Disease Burden Database estimated that in 2019, 23.4% of the global population had experienced binge eating disorder at some point in their lifetime. Binge eating disorder has high co-occurrence with mental health comorbidities, 89% co-occurrence. In fact, 83% co-occurrence with adverse childhood experiences, 63% with substance-related and addictive disorders, depression, anxiety, post-traumatic stress disorder, which tends to more emerge in adulthood, but tends to occur in childhood, neurodivergence. These symptoms often go undiagnosed, and it's thought among experts that oftentimes the eating behaviors develop in order to cope with or mask untreated symptoms. Binge eating disorder also has 80 to 90% co-occurrence with physical health comorbidities, including obesity, diabetes, metabolic syndrome, cardiometabolic disorder, and individually, hypercholesterolemia, hypertension, heart disease. Moreover, this disorder significantly impacts quality of life. It's associated with 0.98 disability adjusted life years per person, and its prevalence is increasing. The market for binge eating disorder is valued at $0.81 billion in the US with a 6% compound annual growth rate. Standard of care interventions for binge eating disorder include cognitive behavioral therapy, behavioral weight loss, interpersonal therapy, and medications in individual, group, and guided self-help format. Medications include antidepressants, anticonvulsants, anti-obesity medications like orlistat, which is no longer FDA approved, stimulants like lisdexamfetamine or Vyvanse, which is now guideline therapy, and GLP-1 inhibitors, which are not standard of care or guideline, but they do have empirical support and increasing use. Other empirically supported interventions include family-based therapy, psychodynamic therapies, humanistic therapy, mindfulness-based interventions, and again, guided self-help formats and group formats have empirical support as well. Unfortunately, all of these standard of care interventions share low treatment success rates that cap at less than 50%, high rates of recurrence between 50 to 65%, and high rates of treatment dissatisfaction and early discontinuation of care. Moreover, most individuals with binge eating disorder, 95% in fact, don't know that they have an eating disorder. 95% never receive a formal diagnosis. 56 to 87% never receive standard treatment, and 85% lack access to health care. Now, I want to address a misconception that we have growing awareness of in the field, and that's we call in the field the swag stereotype that ascribes all eating disorders to skinny, white, affluent young women, typically with restrictive type eating disorders. I wonder if the imagery that came up for you in the contemplative exercise matched any of that misconception. Now, that demographic tends to saturate treatment-seeking populations, which also saturate research samples, though it actually represents less than 5% of individuals who experience eating disorders. So here's a quote from one of my publications, one of the experts in my studies. So much of the eating disorder perspectives and history that we attend to are very female-focused and come out of the female gender orientation. I think anorexia nervosa kind of set the stage for a current understanding of eating disorder pathology and treatment, and anorexia nervosa is so predominantly female. We know, unfortunately, that eating disorders have been hampered by these old stereotypes about who's affected, and that leaves millions of people undetected with an eating disorder. So this misconception needs awareness and it needs dismantling. We need updated information on demographic prevalence, risk factors, and pathology that include the 55 to 90% 95% of folks who are affected who go undetected, underscreened, undiagnosed, and untreated. Another quote, how we think about eating disorders is that anorexia was kind of the granddaddy, the thing we knew first. Then bulimia kind of grew out of that next, and people used to refer to it as failed anorexia. And I would say, in part, that binge eating disorder was thought of initially as being like bulimia, but without the purging. So the same mechanisms. And I would say that traditionally, when I'm talking to my colleagues in the eating disorder field, the dominant mechanisms that have tendency to be most thought of are things like restraint and shape and weight over evaluation. But there's starting to be a bigger push to have a more encompassing view on mechanisms like reward and inhibitory control, emotion, distraction, things like that. I think in part because the restraint stuff wasn't necessarily panning out with binge eating disorder quite as well. So we actually have data now showing that members of the BIPOC and LGBTQ2 plus communities have 2 and 3-fold higher risk and prevalence rates of binge eating disorder than their white, heterosexual, cisgendered counterparts. Yet they are 50% less likely to be screened or diagnosed with an eating disorder, 50% less likely to receive care, and they're represented in less than 10% of research. So here's another quote. If you're a Black woman, if you are somebody who lives in a larger body, if you are an older male, people aren't going to think that your eating habits constitute an eating disorder because you aren't a young, thin, cisgendered white woman. And I think it also makes sense to talk about the specific ways in which underrepresented groups might be struggling that are unique to them and their experiences, rather than just saying anyone can be affected. So, knowing, for example, that if you are a sex or gender minority, you are at much greater risk of developing any kind of eating disorder. Knowing that if you are a member of a BIPOC community, you are very unlikely to get detected with an eating disorder. And that means that you could struggle for a long time. And so, what do we do then to reach these communities in a way that's meaningful? And we also have data that strongly links binge eating disorder with food insecurity. In fact, food insecurity increases risk of binge eating disorder almost twofold, and use of government assistance before the age of 18 increases binge eating disorder risk threefold. We also have studies that have been conducted in food pantries in San Antonio, Texas, and globally that show us that about 52% of food pantry users meet diagnostic criteria for an eating disorder, usually binge eating disorder. 52% also report restricting their food or eating or fasting for more than 8 hours. These reports significantly correlate with increased weight or BMI and increased eating disorder pathology. Now, here's a quote from an expert, one of their patients saying, well, yeah, I have binge eating disorder. I binge eat the first 2 weeks of the month because that's when we have food in the house. And then there's no food in the house the last 2 weeks of the month. So food insecurity sets up this cycle of forced restriction, not voluntary, not related to weight or body shape, size overvaluation, but related to food conservation, a very smart, cognitive, rational tactic. And these studies show the three most common reasons folks report restricting their food are insufficiency, stretching food to make it last longer, attempting to prioritize other family members, and prioritizing medical expenses over food. Now, again, this is not an individual who is restricting food because they feel insecure about their body weight or shape. So they are going to need a very different treatment approach. Most of our treatment approaches currently in eating disorders target body weight, shape, size overvaluation, practice body acceptance, and that might not be really what the active mechanism of the disorder is. We're missing the mark, and that might be why our treatments have such low success rates. So, another factor that's identified as a root cause is stigmatization. It has about 90% prevalence in binge eating disorder and is significantly associated with the development and maintenance of binge eating disorder. It's attributed with about 60% developments or variation among development. Stigmatization can occur in many forms, can be related to body weight, shape, size, to having an eating disorder, to having a mental health diagnosis. Here's a quote from one of my experts in my study. I have a patient with binge eating disorder whose doctor told them, "You're fat every day, so you should exercise every day." That's coming from a healthcare practitioner. And let me tell you, healthcare practitioners and systems were identified as a significant source of stigmatization that contributes to binge eating disorder development and maintenance, as well as healthcare avoidance that contributes to the undiagnosis and untreatment of this issue. So that's coming from a healthcare provider, but that's really what we're telling people as a culture or society. The practitioner just put it into words. So again, sources of stigmatization, it can be internalized, it occurs systemically, and it occurs in our healthcare systems and among our healthcare providers. The impacts of stigmatization cannot be minimized. It directly contributes to the development of binge eating disorder. I don't have that data up here, but 63% of variance in development is attributed to stigma. It contributes to shame, trauma, adversity, poor self-esteem, interpersonal relating, all of which have been identified as factors in binge eating disorder development, isolation, avoidance that worsen mental health and contribute to healthcare avoidance, which then prevent diagnosis, detection, and treatment. So here's another quote. If the eating disorder has been associated with weight gain, then we know for a fact that the individual has been intruded upon by families, doctors, institutions, and there's trauma associated with that. There's trauma associated with being told day in and day out that what you are is not acceptable or lovable or okay. Many people who are living in larger bodies have been teased or bullied around weight, so there's a lot of trauma associated with binge eating disorder. I've got 3 minutes left, so I'm going to kind of skip through these slides very quickly. Stigmatization is important. Trauma and adversity, and not just conventional abuse, neglect, and household dysfunction, but also adverse lifetime experiences, stigmatization, invalidation, mandated movement, food insecurity, chronic dieting. We know that these things impact the brain and the disease psychopathology. There's often trauma associated with movement. Experts associate these environmental factors largely with trauma and adversity of many different kinds. We're doing some work at Nourish to map these. So what can we do as providers? Forget what you think you know about binge eating disorder. Screen indiscriminately, especially in marginalized populations in your CMS, Medicare, Medicaid patients. Evaluate how weight bias and discrimination might impact your patients and how that might show up in you. If you're going to talk about weight and its potential risks, please do so with sensitivity, knowing that you're going to be touching on trauma. We need to be really listening to our patients. Again, forget what you think you know. Listening to patient narratives, exploring social justice therapy, trauma-informed therapy, Buddhist-informed contemplative counseling approaches like Brilliant Sanity, really validating our patients. If you want to learn more, check out our website, nourishedrfi.org, here in the bottom left. Again, most of this is funded by the NCCIH, the National University of Natural Medicine, and we seek to disseminate it through the Nourished Research Foundation. Big thanks to the Nourished team and everyone here today. Thank you so much for your time.